Invasive melanoma is rapidly increasing in incidence. However, early diagnosis and treatment can be curative. Let's take a moment to discuss important staging information and treatment of melanoma. Melanoma follows the traditional T&M staging. Knowing the stage, in particular the tumor depth, is critical for operative planning and excision with appropriate margins. T1 tumors are less than 1 mm in depth, T2 between 1 and 2 mm, T3 between 2 and 4 mm, and T4 greater than 4 mm in depth. An AB status distinguishes the absence or presence of ulceration or a mitotic rate greater than 1. Melanoma in situ requires a 5 mm margin of excision. T1 tumors, which have a depth equal to or less than 1 mm, require a 1 cm margin of excision. Tumors with a depth greater than 2 mm, or T3 or T4 tumors, require 2 cm margins. T2 tumors with a depth between 1 and 2 mm are recommended having 1 to 2 cm margins, depending on the cosmesis and ability to provide adequate tissue coverage. Let's take a moment to discuss some important landmark studies for melanoma management. First, the multicenter selective lymphadenectomy trial, or MSLT1 trial, investigated sentinel lymph node biopsy versus nodal observation in patients with intermediate thickness melanomas. Although sentinel lymph node biopsy did not demonstrate a difference in melanoma-specific survival at 10-year follow-up, MSLT1 showed that sentinel lymph node biopsy does have an effect on disease-free survival. The trial also confirmed the value of the prognostic information of sentinel lymph node biopsy, as well as other important prognostic factors such as tumor thickness and ulceration status. The results of this were further investigated by the subsequent MSLT2 trial, which compared completion lymph node dissection to nodal observation in patients with a positive sentinel lymph node. The MSLT2 trial failed to demonstrate a difference in melanoma-specific survival among patients with sentinel lymph node metastases in comparing these two groups. Current NCCN guidelines recommend sentinel lymph node biopsy be discussed and offered for patients with stage 1B or stage 2 melanomas. This includes clinically node-negative tumors with a thickness greater than 1 mm or thickness between 0.76 and 1 mm with ulceration or mitotic rate greater than 1.